I'll be speaking on anterior segment infections, inflammations, and a few other miscellaneous conditions that commonly occur in the anterior segment following a complicated posterior segment procedure. So let us look at these two patients. Both of them are 65-year-old. Both of them have undergone a diabetic pars plana vitrectomy. One of them has a silicone oil tamponade, and you see two entirely different clinical presentations in the first postoperative week. One has a post-vitrectomy endophthalmitis, and the other one has a post-vitrectomy, a posterior segment fibrin syndrome, or the post-vitrectomy TAS syndrome. If you look at the incidence of post-vitrectomy endophthalmitis, when we were shifting over from the 20-gauge sutured surgery to the transconjunctival sutureless vitrectomy, during that era from 2002 to about 2006 or 7, there was an increase in the incidence of post-vitrectomy endophthalmitis. This could be a learning curve when we were learning how to put in the transconjunctival sutureless sclerotomy. It could be related to the techniques and technology involved, and subsequently there has been a decline and the incidence is very less now. The incidence in the Indian scenario is about 0.02% to 0.08%. The risk factors are a complicated VIA procedures, multiple instrument exchanges, longer operating times, a combined procedure, poor wound healing in a diabetic patients. When vitrectomy is performed for a vascular retinopathy, a phaco-vitrectomy, and interestingly, the absence of silicone oil tamponade or a gas tamponade is a risk factor for development of post-vitrectomy endophthalmitis. This could be because of the fact that the differential surface tension of the tamponading agent seals the wound, while when there is balanced salt solution in the eye, the wound is likely to leak, become hypotonous, and vitreous wick can prolapse through the wound, which acts as a nidus for post-vitrectomy infections. If you look at the percentage of leaking sclerotomies following a sutureless small gauge vitrectomy, about 38% of cases we still do have to suture the wound or resort to other means such as application of diathermy or cryo to the wound to make the wound lips edematous so that it seals on its own. The clinical presentation of post-vitrectomy endophthalmitis is a little different from post-cataract surgery endophthalmitis. In fact, the patient presents usually within less, maybe on the first post-operative day itself, usually less than 1 week following the surgery. The reaction is associated with a lot of fibrin formation in the anterior chamber of corneal edema, and sometimes you do see that the sclerotomy site is necrosed. The patient may either have hypertony or hypotony. The responsible organisms are also different. While it is a gram-positive staph epidermidis, which is responsible for the post-cataract endophthalmitis, we have the fulminant gram-negative infections, especially the Enterobacteriaceae infections with E. coli, Klebsiella, or Pseudomonas, and fungal infections. In our country, we tend to reuse the disposable instruments to cut down the cost for our patients, and this was a very elegant study, a multi-centered study conducted by the Vitreoretinal Society of India, which showed that there was no significant difference in the incidence of post-vitrectomy endophthalmitis even when the instruments were reused, either based on the performance based, and when the instrument was not performing properly, they discarded the instrument, or in some centers, after the instrument was used for a specific number of times, they tend to discard the instruments. Irrespective of reuse of the instrument, it was found that there was no significant difference in the incidence of post-vitrectomy endophthalmitis. This is one of my patients with TAS. The silicone oil in situ had undergone a complicated vitrectomy for a retinal detachment with proliferative vitreoretinopathy. It tends to occur on the first postoperative day itself with limbus to limbus corneal edema and a lot of fibrin in the anterior chamber. This is called the toxic posterior segment syndrome. Well, previously we called this for several years as the fibrin syndrome or sterile endophthalmitis. The onset is usually on the first postoperative day with severe visual blurring, absent conjunctival congestion, there is no pain usually, and presence of plenty of fibrin in the anterior chamber. The risk factors for TPSS could be similar to TAS. It could be procedure related or process related. There is extensive cryo or cyclodestructive procedures. When we use poor quality silicone oil earlier when good quality silicone oils were not available, we used to see a lot of TAS. If you have the suspicion of NAS or an endophthalmitis, you keep the patient in the OP, use topical antibiotic and steroid, observe the patient for a period of 3 hours. If you see that if he is getting better, you continue treatment with the steroids. Otherwise, it's always better to err on the side of infection and go in for a vitreous tap or biopsy and inject intravitreal antibiotics. The sequelae of TARS is chronic inflammation, damage to the trabecular meshwork, and glaucoma, endothelial damage resulting in a decompensated cornea, a fixed dilated pupil, and severe persistent cystoid macular edema. The processes involved could be while you're in your sterilization process, so it is always better to take a look at your sterilization process once in a while and see that everything is in place. Cannulated instruments are used in vitreoretinal surgery also, and even the microvitreoretinal forceps and the scissors that we use do have lumen inside, and the muck that collects in gets voided into the vitreous cavity because of the difference in pressure. The pressure inside the eye is much higher than the atmospheric pressure, so this muck, viscoelastics, PFCLs, residual silicone oil gets flushed into the vitreous cavity and can be responsible for TAS. The management is steroids through all routes. Intraocular pressure monitoring is necessary if your patient is not responding. Once again, I emphasize that it is better to err on the side of infection and go in for a vitreous biopsy and intravitreal antibiotic injection. These are a few other infections that you see. This is a patient who has a sclerotomy site necrosis, a scleritis at that site with the gaping of the wound, and subsequently it healed on its own, leaving behind a small area of thin sclera through which you can see the uveal tissue prolapsing out. This is another patient whom I operated about 20 years back, who came to me recently with an extruding buccal infection, and what looked to me like a scleral, an abscess, which I drained in my OP itself. But his problem was that he was having severe pain. The pain was disproportionate to the inflammation that he had in the eye, and subsequently after buccal removal and a course of systemic antibiotic and steroid, his eye quietened down. What he had was a post-surgical surgical scleral necrosis syndrome. And this is another such patient who had recurrent inflammation, a one-eyed man, a high myopic patient who had recurrent scleritis in the postoperative period. And this is the area of thinning that he has with protrusion of the uveal tissue, which he subsequently underwent a patch graft in that area. If you look at the various causes which are responsible for surgically induced scleral necrosis, it can vary from trauma, infectious pathology, ischemia, toxicity. But most importantly to us as posterior segment surgeon, it is usually a very tight buccal which compresses the posterior ciliary circulation and causes ischemia in the anterior segment, or excessive use of diathermy, especially in long time back when we did an implant. We dissected the sclera and then we placed diathermy on the scleral bed in staggered rows, and those kind of patients were likely to develop CINS in the postoperative period. Here again, it is better to rule out infections, especially bacterial, fungal, and atypical mycobacterial infection, and treat the patient accordingly. For all non-infectious pathology, you upgrade the treatment, starting the treatment with topical and systemic non-steroidal and anti-inflammatory agents, to systemic steroids, to antimetabolites and biological agents if the patient is not responding, and as a last resort, the sclera is debrided and you put a patch graft. Whatever said and done, the patient suffers terribly. To see patients whom you have done a very good surgery who is an attached retina, they are no longer bothered about their visual recovery. What they are bothered about is the severe pain that they have in the post-operative period. This is another situation that is commonly seen when your explant suture gives way and the buccal starts migrating forward. Anteriorly, it comes under the extraocular muscle, and sometimes it may cheese fire through the muscle and come very close to the limbus. And these buccals usually get extrude through the conjunctiva, ultimately get infected, and they have to be removed. Here you can see a sponge extruding in the same way. Suture-related granuloma and implantation cysts are other minor complications, easy to tackle, but they distress the patient who has undergone a prolonged procedure in the postoperative period. This is again a post-vitrectomy eye who had a leaking sclerotomy despite closure of the sclerotomy with the suture, and you can see that the silicone oil has migrated under the conjunctiva, and you can see sago grains like appearance of the conjunctiva. This again, it's very difficult if you try to remove these silicone oil bubbles because they are encysted in the Tenon's capsule and they do not come out. So it's better to leave it alone. For the newcomer or a fresher who is doing vitreoretinal surgery, there is something called the Poole's rule. When you tighten the encirclage while you're doing an explant, to achieve about 2 millimeter shortening, you cut the band about 13 millimeter. This is a rule that all of us should follow. Otherwise, if your drainage is not complete and there is still a lot of fluid present in the vitreous cavity, your natural tendency is to tighten the band and you get an hourglass globe. And this is responsible for anterior segment ischemia. We rarely see anterior segment ischemia now. Previously, there were a lot of such cases because of too much tightening of the encirclage. Now, with the advent of vitrectomy, scleral buckling is a procedure which has become almost obsolete, and we rarely see this complication. This can also cause severe band pain in the patient, a chronic aching kind of pain at the back of the eye, where sometimes necessitate that you cut the band and leave it back in the eye. So these are some of the complications anterior segment complication that can occur in posterior segment surgery, and I thank you very much for your patient hearing.